Welcome to our channel. Today, we are embarking on a vital conversation about the longevity of intimacy and navigating sexual health through the decades. It is a topic often shrouded in silence, yet it is fundamental to our overall well-being and longevity. We are joined by Dr. Aris, a renowned reproductive endocrinologist and longevity specialist, to help us understand the physiological shifts that occur from our 40s through our 60s and beyond. We will be discussing everything from hormonal fluctuations to vascular health, aiming to distinguish what is a natural part of the aging process and what might require medical attention. Dr. Aris, thank you for being here to shed light on this crucial aspect of human health.
It is a pleasure to be here. You are absolutely right to frame this as a health conversation rather than just a lifestyle one. Sexual health is often a canary in the coal mine for systemic health issues. When we talk about the longevity of intimacy, we aren't just talking about libido. We are discussing endothelial function, hormonal balance, neural conductivity, and tissue elasticity. My goal is to normalize these biological transitions so that patients feel empowered rather than broken. We need to move away from the idea that intimacy expires and understand how to adapt our expectations and behaviors to our changing physiology.
Let's dive right into the 40s. For many, this is when the first subtle shifts begin to appear. We often hear about perimenopause for women, but it seems to catch many off guard. What is happening beneath the surface during this decade? It seems like a time of hormonal chaos, where the body is preparing for a major exit from the reproductive years, but the symptoms can be quite confusing and inconsistent. How should we interpret these initial signs of change, and does this impact the physical experience of intimacy immediately?
In the 40s, specifically for women, perimenopause is defined by the erratic nature of estrogen and progesterone production. It is not a steady decline yet. It is a roller coaster. This volatility can lead to the initial signs of vaginal dryness or a thinning of the mucosal lining, which we clinically call atrophy, though I prefer the term tissue remodeling. Biologically, the tissues become less responsive to arousal cues because blood flow isn't surging as quickly as it used to. It might take longer to achieve lubrication, which is a direct result of these hormonal signaling gaps. It is a physiological delay, not necessarily a lack of desire.
That is a very helpful distinction, delay versus lack of desire. Now, shifting to men in their 40s, we often joke about the midlife crisis, but is there a biological basis for changes in their sexual health during this decade? We hear about testosterone dropping, but is it as dramatic as the changes women experience? I imagine that lifestyle factors, career stress, and cortisol might also play a massive role here, potentially overshadowing the hormonal picture. What is the clinical reality for men in this age bracket?
For men, the 40s are characterized by a more linear, gradual decline in testosterone, about 1% per year, unlike the steep drops women face. However, the 40s are often the peak physiological stress years. High cortisol levels directly inhibit testosterone production and, crucially, impair nitric oxide pathways. Nitric oxide is the chemical messenger that tells blood vessels to relax and open up. So, in the 40s, men might notice their recovery time, the refractory period, lengthening. Instead of minutes, it might become hours. This is the first sign of vascular aging and neuroslowing, often exacerbated by lifestyle stress rather than purely hormonal failure.
Moving into the 50s, this feels like the decade of profound transition. For women, menopause is usually established. We are no longer talking about fluctuations, but a new baseline of very low estrogen. How does this systemic drop impact the mechanics of intimacy? I've read about changes in pH balance and elasticity, but it can be difficult to understand how that translates to daily life. It seems like the body is entering a completely different state of being that requires a new manual for operation.
The 50s are indeed the turning point. With the cessation of ovarian estrogen, the tissues of the vulva and vagina lose collagen and elastin rapidly. This leads to a loss of rugae, the accordion-like folds that allow for expansion. Consequently, the tissue becomes less elastic and more prone to micro-tearing during intimacy. Furthermore, the pH environment shifts from protective acidity to a more neutral state, altering the microbiome and increasing susceptibility to infections. This is where the use it or lose it principle begins to apply. Regular blood flow to the area is essential to maintain tissue oxygenation and prevent fibrosis, or hardening of the tissues.
That concept of fibrosis and tissue hardening is quite sobering. Now, for men in their 50s, are they facing similar structural changes? I understand that prostate health becomes a major conversation piece during this decade. It seems that while women are dealing with a lack of hormones, men might be dealing with the physical enlargement of the prostate gland, which complicates function. How does the male physiology navigate this decade? And are there other hormonal factors at play beyond just testosterone?
Excellent question. In the 50s, men face a double whammy. First, we see a rise in sex hormone binding globulin, or SHBG. Think of SHBG as a sponge that soaks up free testosterone, making it unavailable to the tissues. So even if total testosterone is okay, bioavailable testosterone drops. Second, the prostate often enlarges, benign prostatic hyperplasia. This structural change can put pressure on the urethra and nerves, affecting both urinary function and ejaculation. The force and volume of emission decrease. It's a mechanical obstruction combined with a hormonal bioavailability issue, requiring a shift in how men view their sexual performance.
It becomes clear that both sexes are dealing with significant hurdles in the 50s that are purely biological. Let's talk about the psychology of this for a moment. If the mechanics are slowing down or changing, that must require a massive mental shift. We live in a society that prioritizes spontaneity and speed. How do couples usually cope when the body says, slow down, or we need help? It feels like there is a grief process involved in letting go of the effortless function of the 20s and 30s.
There is absolutely a grief process. I tell my patients that in the 50s, we move from spontaneous desire to responsive desire. You may not feel the urge out of the blue. The body needs to be physically stimulated to trigger the mental desire, which is the reverse of our youth. Psychologically, if a couple clings to the script of their 20s, they will face frustration and avoidance. The 50s require an intentional reframing. Intimacy becomes less about the destination, orgasm, and more about the sensory experience. Accepting that aids like lubricants or medications are tools, not crutches, is vital for psychological resilience.
Now, let's talk about the 60s and beyond. We have navigated the hormonal cliffs of the 50s. What defines the 60s? I suspect this is where general systemic health, specifically cardiovascular health, becomes the dominant factor. We often hear that the sexual system is a vascular system. If someone has maintained their health, can intimacy continue into the 70s and 80s? Or is there a biological hard stop where the tissues simply retire?
In the 60s, the conversation is almost entirely vascular and neurological. There is no biological hard stop. Humans are capable of intimacy until the end of life. However, sexual function is heavily dependent on the microvasculature, the tiny blood vessels. If a patient has atherosclerosis or hardening of the arteries, the tiny vessels in the genitalia are often the first to get blocked, long before the heart arteries. So maintaining intimacy in the 60s is synonymous with maintaining heart health. We also see a decrease in tactile sensitivity due to nerve aging, meaning stronger, more direct stimulation is required for both men and women.
I want to circle back to the use it or lose it principle I mentioned earlier. In the 60s, this is critical. For women, regular tissue expansion prevents the vaginal walls from fusing or shrinking. For men, regular erections, even if not resulting in intercourse, oxygenate the cavernous tissue, preventing collagen deposition that leads to permanent stiffness or curvature. It is a form of physical therapy for the pelvic organs. The tissues need blood flow to remain pliable. Activity preserves function. Inactivity accelerates atrophy. It is that simple and that clinical.
That is a powerful motivation, but we must distinguish between natural aging and disease. You mentioned atherosclerosis, but what about other conditions? How does a patient know if their slowing down is just normal aging, Dr. Aris's responsive desire model? or if it is a symptom of a pathology like diabetes or severe neuropathy. It seems dangerous to just assume, I'm old, so this doesn't work anymore, potentially missing a diagnosis.
Precisely. Normal aging is a slowing of processes, longer time to arousal, reduced lubrication, less forceful ejaculation. Pathology is a functional blockage. For example, in diabetes, high blood sugar damages both the nerves and the blood vessels. If a patient has zero sensation, that is neuropathy, not aging. If a man has zero erectile function regardless of stimulation, that is severe vascular disease, not aging. If a woman experiences bleeding post-intimacy, that requires immediate investigation for pathology. We must not dismiss symptoms as just getting old. Pain is never normal aging. Complete loss of function warrants a medical workup.
Let's move towards solutions. We have painted a realistic, albeit slightly challenging picture. For those in their 40s, 50s, and 60s listening, what are the medical levers we can pull? We hear about hormone replacement therapy, HRT, local estrogens, and PDE5 inhibitors like Viagra. Are these standard maintenance tools now? How should we view these interventions? As rescue medications or preventative strategies for longevity?
We should view them as tools for health span. For women, local vaginal estrogen is the gold standard. It's safe, stays local, and restores tissue quality, preventing UTIs and restoring elasticity. It is not just about sex, it's about comfort. For men, PDE5 inhibitors facilitate blood flow, but they don't create desire. They fix the plumbing, not the engine. I often prescribe them for penile rehabilitation to ensure oxygenation. And broadly, HRT, when started in the appropriate window, can protect bone, brain, and heart health, which indirectly supports sexual longevity. These aren't just for performance, they are for tissue preservation.
And finally, beyond the pharmacy, what about the lifestyle and psychological solutions? You mentioned reframing earlier. If we strip away the medical interventions, what can a couple do tonight to improve their intimate longevity? It seems that communication becomes the most potent aphrodisiac as we age. How do we cultivate that, especially if we have been in a silent routine for decades?
The most powerful intervention is the sensate focus technique. This removes the goal of intercourse and focuses on touch and sensation. It reduces performance anxiety, which is the killer of intimacy in older age. Physically, pelvic floor therapy is transformative for both genders to maintain muscle tone and blood flow. And never underestimate the power of cardiovascular exercise and a diet low in sugar. If it's good for the heart, it's good for the pelvis. Intimacy evolves. It changes shape. If you embrace that evolution with compassion and open communication, your sexual health can thrive well into your 80s.